Welcome to Pharmacy Friends. Pharmacy Friends is a podcast dedicated to bringing industry experts to the same table to talk about what is happening in pharmacy today, what is coming in the future, and most importantly, what it means to you. In this episode, Navigating the RSV Vaccine Frontier, join Maryam Tabatabai, a clinical information expert at Prime and Magellan RX, as she talks about the new frontier of RSV monoclonal antibodies and vaccines with Dr. Scott Roberts, an infectious disease expert from Yale University, who is navigating RSV season both professionally and personally. In this episode, these thought leaders discuss why RSV is a current hot topic in the healthcare industry and how it's impacting both healthcare systems and patients who choose to get the vaccine. Listen to their discussion covering the CDC guidance on obtaining access, the impact and risk factors of the illness and vaccines in both pediatric and adult populations, along with some conversation about how RSV monoclonal antibodies and vaccines can be administered. So let's dig in.
RSV stands for respiratory syncytial virus, and this is a very common virus that actually infects almost all kids by age 2. And the reason there's a lot of interest in this now is we're getting a greater awareness of how impactful this is, especially at the extremes of age. I think your email and this podcast are certainly quite timely, just based on the fact I'm deciding what to do with my wife and our anticipated newborn. And then, also my oldest kid, I was notified this week that there was an RSV case in his class.
Hello and welcome to our podcast. Today's hot topic is RSV, a common virus with significant impact to the healthcare system. I'm Maryam Tabatabai, Vice President for Clinical Information at Prime Therapeutics, and I'm your podcast host. As our CEO, Mustafa Kamal, says, our purpose is to reimagine pharmacy to provide the care we would want for our loved ones. And what my team and I do is to use evidence-based medicine and our drug information skills to provide the most clinically relevant information for our clients and patients we serve. So, with that in mind, I am delighted to welcome my guest, Dr. Scott Roberts, an infectious disease specialist from Yale, to talk about RSV. Dr. Roberts graduated from the Albert Einstein College of Medicine. He did his residency at University of Michigan at Ann Arbor and fellowship at Northwestern. Welcome, Scott.
Hi, Maryam. Pleasure to be here.
So I'll share a backstory for our listeners. How Scott Roberts and I got connected was when I came across a very well done Yale article on RSV that he had co-authored. So Scott, when I had reached out to you, I distinctly remember you had said you were in the middle of a quote unquote rough 2-week stretch of ID consults in the hospital. But, despite being extremely busy with your patient care, you still took the time to communicate. And I thought we had some really good conversations. So I felt I'd found, the right podcast partner for this podcast. Do you remember that?
Yeah, I remember it well, Maryam, and I'm glad you ultimately reached out. I recall being in quite a busy 2-week block, and I was actually at the time seeing patients with RSV in our hospital, and your email was quite timely. So I'm grateful for the opportunity to be here and share what I know about RSV and what changes have occurred over the past year.
Well, I'm really grateful to have you here, and I'm super excited to have this conversation together. So I hear that you had an interesting start to your ID career, Scott.
Yes, I actually interviewed and I signed my contract with Yale at the very end of 2019, right before COVID hit. And my start date was right at really the tail end of the first wave. So it was a very interesting experience to not only get involved with infectious diseases as COVID was coming about, but get involved with infection prevention. And a large majority of my role now is focused on the prevention of healthcare-acquired infections in patients and staff. So it's been a great learning experience, and I'm happy to share what I've learned over the past few years, especially related to RSV.
I'd love that. Well, let's dive into RSV. So we know a lot about flu, right? And certainly about COVID-19. But what is RSV, right? We heard it so much more, I think I would say on the news last year too. Why is it such a hot topic?
RSV stands for respiratory syncytial virus, and this is a very common virus that actually infects almost all kids by age 2 and causes reinfection very commonly. It's a winter respiratory virus. It generally starts in the late fall, October, November, and peaks around January, February. And the reason there's a lot of interest in this now is we're getting a greater awareness of how impactful this is, especially at the extremes of age. So we think classically about children as being very impacted by RSV, and this is the leading cause of lower respiratory tract infection in children under the age of 1. About 60 to 80,000 children under the age of 5 are admitted each year due to RSV, and 2 to 3 out of 100 will ultimately need to be hospitalized. Every year, there's about 100 to 300 children who die from RSV, and those at risk include premature babies less than age 6 months, and those with chronic lung disease and immunosuppression, just to cite a few.
Wow, those numbers definitely get attention. So, can we predict what type of RSV season we might have? In other words, are there any indicators to predict, if the season will be mild or severe? I imagine that might be a question folks might have, especially with the holiday season. That's Thanksgiving and holidays right around the corner.
That's a great question. And, I've certainly been humbled many times before in my predictions, but my best guess is that we would have really a slow return to pre-pandemic normalcy in terms of respiratory viral season. Last fall we had an unusually bad RSV season, which was both bad in terms of the degree of severity of cases of RSV and how many cases came into our hospital. And also, it was much earlier than any of us had anticipated. I can say this season is certainly here. We are going up in terms of our local numbers that I'm seeing here at Yale, sort of on a week-to-week basis, and it remains to be seen where this current wave is going to peak for RSV. I can tell you my numbers today in our hospital. We have 35 COVID patients, 19 with RSV, and 3 with influenza. So, RSV remains pretty prevalent right now in our communities and is only on the upswing.
Yeah, and we also are continuing to watch the CDC tracker in terms of what the trends look like with RSV as well as other infectious diseases. So, yeah, thanks for sharing those numbers, and especially what you're seeing kind of with boots on the ground. About 2 months ago, the CDC warned that RSV activity was picking up in the southeastern part of the United States. Is that like with you being in the Northeast, but is that a bellwether for RSV for the rest of the country?
It's an interesting observation, and certainly for the past few respiratory viral seasons, not only RSV, but other viruses as well, including influenza and some of the COVID variants, seem to start in the southeastern United States and hit there first before then traveling elsewhere to other regions of the United States. I think right now we don't have a great sense of why that is, but it's probably multifactorial and may depend on regional differences in public health policy, increasing travel to certain areas, and even the percentage of kids who are in school.
That's really interesting. Something to keep in mind. So, what kind of impact does RSV have on healthcare system? You talked about some of the stats earlier, but just kind of looking at it, before we dive into the conversation and talk about pediatrics.
It has quite a profound impact from the pediatric side of things. I can give you an example. Last year, which was an unusually bad RSV season that hit all at once and hit us very hard at Yale, there was a time, 1 week, when we had only a single pediatric ICU bed with 1 ventilator left, and we had to start thinking about triaging. And I never thought we would get to that point, pre-COVID, but it
Hmm.
just shows the burden of disease in that population. I do want to highlight a recent study in JAMA that looked at 600 infants across 39 hospitals in 27 states who required ICU level care. And the most striking statistic to me was that 81% of those infants had no underlying comorbidity that put them at risk for severe RSV. So, not only is this a very ubiquitous virus in our pediatric communities, but it hits healthy kids with no issues quite hard.
Wow, I didn't realize that RSV is that common in infants. I mean, including healthy ones, 81%. I mean, that certainly gets my attention. All right, well, let's talk about the new options for infants then. I'd like to begin with nirsevimab or Beyfortus, which is a trade name. Maybe just tell us, what is it? What's the efficacy like? Basically, how well does it work?
This is a monoclonal antibody. It's given as a single shot in the thigh muscle of an infant. It targets the prefusion conformation of the RSVF glycoprotein. And, a couple things right off the bat, it's a passive immunity treatment. It's not active. So after it wears off, that infant will not have immunity to RSV. The good news is that this is long acting. So it lasts for up to 5 months. It's most effective right after it's given. And then over time, over those 5 months, it will slowly wane. And the current recommendation is that infants less than 8 months during or entering RSV season are eligible for this. And then infants 8 to 19 months at risk for severe RSV.
So you have two buckets in terms of the infant population. So that recommendation kind of in the healthy population and the more of the at that higher risk population. Okay. And what about the study, the main study that led to FDA approval, Medley? What type of data did we see there?
The Melody study looked at healthy late preterm and term infants who were at least 35 weeks of gestation entering their first RSV season. They found a 75% reduction in RSV disease and a 60% reduction in hospitalization. There was another study called the Medley study, which looked at higher risk infants, so those born less than 35 weeks gestation or with other medical problems that put them at risk for severe disease. And in the first RSV season, the incidence of RSV was 0.6 in the nirsevimab group and 1.1% in the palivizumab group, showing that there's similar efficacies. But also, they noted that the safety profiles between the two drugs were very similar, if not even better for the nirsevimab arm.
Got it. So Melody was for the healthy population, and Medley was for those infants that were, preterm or high risk infants. Okay. So what were some of the side effects that were seen in with this agent?
In general, they were found to be infants who received nirsevimab had very few side effects. The uncommon ones that did present were most likely to be rash within 14 days after the dose was administered, and injection site reaction within 7 days of the dose being administered.
Okay. So I think one of the issues that's unique right now, anyway, with nirsevimab, with Beyfortus, is that issue of access. We know that the demand for the product has outstripped the supply of what's available. So there's a supply-demand issue going on with Beyfortus, and manufacturers also put out a statement regarding that. But the CDC has some recommendations too in light of what's going on with access. What is the CDC recommending at this point?
Yeah, right now we know that there's significantly more demand than there is supply. And we're really just starting RSV season. The CDC recently came out with recommendations of how to triage dose allocation given this supply shortage that is being overwhelmed by demand. Right now, they're recommending for infants less than 5 kilograms. The recommendations are unchanged. So it's still recommended to do a single 50 milligram dose now. However, for infants greater than 5 kilograms, who require a 100 milligram dose, it's recommended to administer that really just for the infants at high risk. So that includes those who are young, so less than 6 months, those who have underlying conditions that place them at high risk. And it's recommended to avoid using 250 milligram doses for infants greater than 5 kilogram to really save that supply of the 50 milligram dose for those young below age 5 kilograms. It is recommended to suspend use right now in palivizumab eligible children aged 8 to 19 months, except in some specific situations, one being American Indian or Alaskan Native infants 8 to 19 months of age, where travel to get monthly palivizumab may be quite difficult.
So basically, what I'm hearing you say is the CDC is recommending rationing the drug, basically, and to prioritize it for the most vulnerable. Does that sound accurate?
That's correct.
Okay, got it. So let's move on to Abrysvo for maternal administration. And I will point out that this, in terms of, again, that passive immunity for maternal administration, but I would love for you to kind of explain that a little bit more to our listeners of how that works. Like, how well does it work? What's the efficacy? Tell us about Abrysvo, the vaccine.
Yeah, this is a vaccine that's given to pregnant women. And I should note the phase 3 trial was done in women who are 24 to 36 weeks of gestation. And the goal here is to induce an antibody response in the mother that then traverses through the placenta and into the fetus, conferring passive immunity in the fetus that will last after birth. I think in the study, when we look at the 32 to 36 weeks gestation group, the vaccine efficacy against severe lower respiratory tract disease caused by RSV was 91% at 90 days in the newborn and 76% at 180 days in the newborn. There was a statistically significant difference in vaccine efficacy against lower respiratory tract disease that was not reached at 90 days, but was achieved at 180 days with a vaccine efficacy of 57%.
Got it. And then what about safety? What are some side effects to be aware of with Abrysvo, with the vaccine?
The most common side effects were localized, such as injection site pain and reactions, and then some systemic symptoms such as fatigue, headache, muscle pain, nausea, and joint pain. I do want to raise the issue that there's been a lot of talk about preterm births in this vaccine study. And the study found that in the vaccinated arm, there was a 5.7% chance of preterm birth compared to placebo, which was 4.7%. This was not statistically significant. So the data right now for this trial is insufficient to establish or exclude a causal relationship between preterm birth and vaccination. So really because of this, the FDA and the CDC had recommended the vaccine be administered just at that 32 to 36 weeks of gestation. I will also note that a vaccine from GSK that operates through a similar mechanism was halted early due to a significant increase in preterm births. And so because of that, there's a lot of attention being given to this right now, and hopefully we'll have a better answer as we see post-marketing surveillance studies.
I'm glad you brought up the preterm birth issue, Dr. Roberts, and kind of explaining and putting it into context in terms of also what that approval is for the 32 through 36 weeks of gestational age. That's very helpful. So now we have two new options, right, for the pediatric population. We have nirsevimab Beyfortus, and we talked about some of the access supply issues, and then we have Abrysvo for maternal administration. So what does, I guess, appropriate patient selection look like with these options?
That's a great question, Maryam. I can speak a little bit toward a personal experience here. My wife is currently in her 3rd trimester of pregnancy, and we are currently grappling with that exact question. And I think it ultimately comes down to the risks and benefits of each and the access to each. And so is the benefit of preventing RSV in the newborn, does that outweigh the risk of preterm birth or a side effect from the vaccine in the mother? And that question may change depending on whether or not there is access to Beyfortus or not. And certainly in my own community, just asking around, there is not widely available Beyfortus. So that's a decision that we are struggling with right now. But it is really important that anyone who is pregnant and will be eligible for either of these therapies have that discussion with their healthcare provider about access and about risks and benefits of that going forward.
Well, first of all, congratulations to you and your wife. That's exciting news.
Thank you.
And as I hear you talk about this, I think there's also a health equity component that comes into play. Thoughts on that?
Yeah, absolutely. I think anytime we see these supply issues that requires allocation to the highest risk individuals, we certainly saw this with COVID, where we see disparities in equity and access, and certainly some patients who are unable to access or who even have healthcare providers in some regions who are unaware of access and who qualifies and who does not qualify. So I think we in the public health sector need to do the best job we can about communication to areas where there may be inequity in care and access to these vaccines and monoclonal antibodies.
I completely agree. And I guess too, as I was hearing you kind of talk about that shared clinical decision making, when that conversation and where that conversation occurs is also relevant and in light of the access issues with Beyfortus, in terms of, does that conversation start at the PCP or the OB level, before the baby's born, especially since Beyfortus might not be an option if there's no supply to be had. So, I think that's any thoughts on that?
Yeah, I think that's a challenging question for a lot of public health intervention that we're trying to achieve right now in terms of educating providers on both the maternal side and the newborn side about the availability of these products and who is eligible for these products. And just citing another personal example, we saw definitely we had differences, my wife and I, between our OB providers and our primary care providers and our pediatricians about who was aware of this, who's offering it, and who's aware of the risks and benefits of administering these.
Wow, really interesting, right? So to piggyback off of that, where are these medications, vaccines, where are they normally given?
Right now, they're normally given in through prescription in physician offices in the outpatient setting. For the maternal vaccination through OB offices or PCPs, and then with Beyfortus through pediatricians' offices, or at the hospitalization where the birth occurs prior to discharge.
Now, I hear New York is doing something to address potentially that vaccine equity and access issue. Do you have the latest there, or are there some things you could share with us in terms of what New York is doing?
Yeah, New York State is now allowing pharmacies to administer the RSV vaccine to older adults and now pregnant mothers as well. So this can be done without a prescription. It can be done in the pharmacy, which I certainly hope is going to improve compliance with these vaccines and increase uptake and reduce some barriers to care and receiving these.
Very interesting. So I guess as we talked about kind of this access issue, right, that's going on with nirsevimab currently. But as you look ahead, where does Synagis fit into all of this, right? You mentioned palivizumab earlier in terms of the CDC's interim recommendations, but what about Synagis? Where does it fit in?
Yeah, this is a more of an older monoclonal antibody, palivizumab, which historically has been given to some children younger than 24 months of age with certain underlying conditions that put them at high risk for severe disease and can be given once per month during the RSV season. I think things will change a lot with Beyfortus, and the what I'm envisioning when supply of Beyfortus goes up is often they would only use palivizumab when Beyfortus is not available, or if an infant previously did meet criteria for receiving palivizumab. So I'm sure a lot will change, and it will change season by season as supply ramps up.
Well, the pediatric piece is certainly fascinating, and I really appreciate all your insights there. I think what we'll do now is let's switch gears and talk about RSV in adults, different patient populations. So, I guess maybe just to kind of level set, how does, I guess, RSV affect the adult population?
RSV certainly does impact the adult population, and I think we're learning more about this over time as we understand the burden of disease at the extremes of age. Age is certainly one of the biggest risk factors for having a bad outcome after an RSV infection, although there's many other pre-existing conditions that can put patients at high risk, and that includes, immunocompromised status or a low immune system for any reason, or pre-existing pulmonary disease, just to note a few. There are 60 to 160,000 older adults hospitalized with RSV every year, which ultimately leads to 6 to 10,000 deaths every year in adults due to RSV.
Wow, that's incredible. So previously, we did not have any vaccines for RSV. We now have two FDA-approved vaccines for adults. Let's talk about them. We have Abrysvo, which is the same as the one that's approved for maternal administration that you spoke about. Maybe just kind of start there and talk about Abrysvo and how does it work? What's the efficacy like with that?
Yeah, Abrysvo studies were recently published from a large phase 3 trial in immunocompetent adults over age 60. And this vaccine, as well as RSV, which we'll talk about. These are both recombinant vaccines against the RSV F protein antigen, which is stabilized in the pre-fusion conformation. When we look at Abrysvo, the vaccine efficacy was 67% for preventing RSV with greater than or equal to 2 symptoms, and 86% at greater than or equal to 3 symptoms for lower respiratory tract disease. There were no cases of severe RSV-associated lower respiratory tract disease with Abrysvo in the trial, but 2 cases in the placebo group.
And so, what are some of the side effects with Abrysvo?
In general, these were really well tolerated. The most common adverse events were fatigue, headache, injection site pain, and muscle pain. In 1% of trial participants, they had a grade 3 reaction, which prevented them from doing their daily activities.
That's actually helpful information to know in terms of what actually can prevent individuals from doing their daily activities. So thank you for sharing that. Okay, so that was Abrysvo. Now let's switch gears and talk about RSV. How does that work? Tell us a little bit about that and the efficacy there as well.
RSV is also a recombinant vaccine against the RSVF protein. The difference here is that it has an adjuvant, with the goal being a higher immune response elicited in those who get vaccinated with the adjuvant. The efficacy here was 83% for RSV-related lower respiratory tract disease. The vaccine efficacy was even higher in older patients. So in ages 70 to 79, it was 94%. And in those with one comorbidity, it was 95%. The efficacy was 94% for severe RSV-related lower respiratory tract disease. So this was really impressive data.
And what about side effects with RSV?
Here, it seemed, in comparison to Abrysvo, more patients reported side effects. There was injection site pain reported in about 2/3 of participants, fatigue in 1/3, and then some others were myalgias, headaches, and joint pains. And about 4% of patients had grade 3 reactions, which prevented them from doing daily activity. I will also note that both vaccines here, there was a rare report of inflammatory neurologic conditions in both that remained in very few numbers of participants. And there was also a slight uptick in patients who were diagnosed with atrial fibrillation in the vaccine group when compared to the placebo group.
That's great information to be aware of. And of course, post-marketing studies as well will be assessing some of these risks. So we'll certainly be watching there. Dr. Roberts, when I was looking at the CDC recommendations for adult RSV vaccines, the language seemed a bit more open in terms of who should get it. What does, I guess, appropriate patient selection look like for the adult population? We talked about it with pediatrics, but what about for adults?
Yeah, that's a great question. And the CDC in their language noted that adults who are eligible may receive the vaccine, after a discussion with their healthcare providers. And I think a lot of this is to do with the fact that we need to understand who are the people who will benefit most from the vaccine. Is it everybody over age 60, or is it those over certain age groups with underlying conditions? Neither study included an arm with immunocompromised patients. So we also need to understand in that group, what should we do? And then I think the other reason for that was monitoring some of these side effects in greater detail in these post-marketing surveillance studies, such as the inflammatory neurologic conditions and atrial fibrillation.
That's very helpful. So again, that shared clinical decision-making comes into play here with the adult population as well, it seems.
That's correct.
Okay. So where are these vaccines normally given? Right. We talked about that again with the peds piece, but what about kind of the site of service, if you will, for the adult vaccines?
In general, these are prescriptions, so it would be medical clinic or PCP offices. However, as we noted in New York State, and certainly I hope other states follow their lead, these are being administered without prescription, which is really only going to improve access and uptake of these vaccines. But in general, the majority of the time, these remain with prescriptions.
You can get them at the pharmacy as well in terms of the administration. And I believe RSV vaccines are covered under Medicare Part D. So I think that's just another piece there. So, well, okay. thanks so much for your insights on the adult side. If you're okay with it, I've got a couple of rapid fire questions for you.
Absolutely.
Okay, great. Are you ready?
I'm ready.
All right, here we go. All right, my first question, and by the way, this is one that I've been asked several times by folks. Can the RSV vaccines be co-administered with flu and COVID-19 vaccines?
Yes, the data we have now show that it is safe to administer the RSV vaccine with the flu vaccine, with the COVID vaccine, or even all three at the same time. The one thing I do want to note is that with co-administration, oftentimes the side effect profile can be higher, so that injection site reaction, some of those symptoms such as fatigue, headache, muscle aches, may have a higher incidence with co-administration than with single vaccine administration. It is safe to be given at the same time, but if anybody's worried, it is also okay to space these out by 2 weeks, and that's also more than okay.
All right, second question. Can you get both Beyfortus and Abrysvo?
Right now, there is not a recommendation to get both vaccines because either one will confer sufficient antibody response in the newborn to prevent that severe RSV disease. The one caveat I will note to that is that we need to have the vaccine be administered at least 2 weeks before the delivery to confer that antibody generation in the mother that then passes through the placenta in the newborn. So if delivery occurs before that 2 weeks have hit after vaccination, we can't state that the Abrysvo has been sufficient enough to confer immunity in the newborn. And then in that case, I would go ahead and administer the Beyfortus.
That's really interesting. I guess it brings up the question of vaccines and record keeping. And even though Beyfortus is not a vaccine, right? It's monoclonal, as you mentioned previously. But that's a great topic for maybe another conversation. Okay. Third question. Are RSV vaccines for adults annual vaccines? I guess sort of like the flu shot.
Right now, we don't know yet. I think what we are seeing is the preliminary data from both of the trials where we're starting to see those participants entering their second RSV season, and we are able to see how well each is doing. And I'm pretty optimistically able to report that both seem to still have induced immunity in the participants, even in their second year. Some of that antibody response has waned. The efficacy is not to the level it was in the first year, but it is still quite effective in the second year for those individuals. So I think time will tell how often we do need these vaccines.
Got it. Okay. So, Dr. Roberts, we have covered a lot of great information. I also really appreciate you sharing your personal journey as you and your wife are navigating this landscape as well. So, I'm curious, are you and your wife making any progress with finalizing baby names?
That is another great question, Maryam. We are grappling with that right now. I will say we are leaving the sex of the baby a surprise, and we have great girl names, but we are struggling a little bit with boy names. So it remains quite a challenge in our household right now, really on a daily basis about what the names will be.
Well, wishing you all the best there. So, Dr. Roberts, it has been an absolute pleasure talking to you. I'm so grateful to have you join me today. Thanks for your time, your expertise, the clinical pearls that you shared, and really that rich dialogue. I really appreciate it and hope you'll come back and join us soon.
Yeah, I really want to thank you, Maryam. It's really a pleasure to be here and share what I know about RSV. I think your email and this podcast are certainly quite timely. Just based on the fact I'm deciding what to do with my wife and our anticipated newborn. And then, also my oldest kid, I was notified this week that there was an RSV case in his class. So this is a very timely podcast for me. And I'm really grateful for the opportunity to share some of this knowledge to the listeners.
I'll hope you and your family all stay healthy. And huge thank you also to all of our listeners for joining us. I look forward to having you join our future podcasts and wishing everyone happy holidays. Thank you so much.
Thanks for joining us for this episode of Pharmacy Friends. Want more insights about the latest trends? Subscribe to our Pharmacy Friends podcast. An upcoming 2-part episode gives insight into GLP-1 drugs, which are common treatment for type 2 diabetes, and in recent years, select drugs in this class have been approved for weight loss. Our leaders discuss the latest trends and advancements in these therapies and highlight a real-world analysis of GLP-1 drugs for weight loss. To get more of our latest perspectives on a variety of healthcare industry hot topics, visit our newsroom and subscribe to our content.